Please.
Good evening, everybody. On behalf of Asami India, I welcome you all for this master class of month of July. It is Delhi State which is going to take the leads in this. The theme of this is non-union and management of non-unions. We have eminent speakers in the form of Dr. Bari, Professor Bari from Bangladesh, Dhaka, and Dr. MANISH from India. I'll hand over the proceedings to Shamsul now.
Thank you, sir. Thank you, everybody. Thank you and good evening on behalf of Asami India. Today we are having our next session of master classes, and the theme is non-union. So our first speaker is Professor Bari, sir, who needs no introduction. He's head of Bari-Ilizarov Center, Bangladesh, and honorary professor of Ilizarov Center, Kurgan. So now I request Bari sir for his presentation on infected non-union.
Okay. Okay, can I start now? One second. Okay. There is screen rook vocal. It is our say. তারপরে ফাইল কই আগে কি মিনিট ঢুকছিলি হ্যাঁ বেশি যাবে কেন নো 1 মিনিট দেন স্ক্রিন এটা ঠিক আছে হ্যাঁ তারপরে জয়েন দিলে আসবে না পাওয়ারপয়েন্টে যাবে পাওয়ারপয়েন্টে ঢুক 1 minute প্লিজ something wrong yes bottom screen okay visible
great
visible
yes sir
can you hear me okay dear friends I am very much grateful to Asami India for inviting me to talk on non-union, especially infected non-unions of the long bones. And as usual, always my training place. These are the things, you know, I always love to show all these pictures. This is now, I should tell, this is our National Institute, 1,000 bedded, biggest in the world now, trauma and orthopedic. And at present, I am working in these two hospitals. These are the biggest diabetic hospitals in Southeast Asia. My center, you know, and these are the recent with the new director of the Bursov. And you can see here, young new director and professor. You can know the Ilizarov method has been awarded nowadays more than 100 countries of the world since 1981. And now, if you look at this, this definition, I thought myself that what will be the definition of the non-union? Arrest of the bony fracture repair process with the formation of fibrous or cartilaginous tissue in between the main fragments, and the fracture has remained ununited for 6 to 9 months due to biological or mechanical failure judged by clinical and radiological evidence. Now, what are the main issues? You all know all these things: bone loss, soft tissue loss, infection, gap non-union, scarring, deformity, shortening, bone and muscle atrophy, diffuse osteopenia, psychological problems. And if we talk about the infected non-union, there are two schools of management. One is conventional method and another is the Ilizarov management. So, dear friends, today the orthopedic surgeons that we are treating all these kinds of conventional and Ilizarov methods. If you think about the conventional method, modalities take a long time to heal, need multiple operations, and you can get the complications as well as the failures. Often it is very frustrating to the surgeon as well as to the patient. Simultaneous treatment by Ilizarov technique, radical debridement, bone transport, acute shortening, and then lengthening. And what are the strategies? Two strategies treatment. If you think about the stage 1, infection eliminations, radical debridement of necrotic and infected tissues, and of course, you're applying sometimes the antibiotic fluids and the cements. And in stage 2, reconstruction of the bone and soft tissue, and sometimes you need to go for flaps, autogenous bone graft, cancellous, cortical, and vascularized. Now, if you think about the infected non-union classification, you'll see Rosen et al. In AO manual have divided this into two broad categories. Infected non-draining non-union, which is further divided into quiescent and active. Quiescent, again, dry non-draining, all these at least 3 months, and active non-draining but with abscess and the fever, and infected draining non-union. A new method classification of the infected non-union is proposed depending on the severity of the infection, the opposition of fragments, and the presence or absence of the deformity. Now, classification that I told you indicates guidelines treating the infected non-unions. There are 3 types. Type 1, this is very simple with mild infection. Type 2, fragments in apposition with moderate to severe infection with moderate to severe, and type 3, which is difficult for the orthopedic surgeons, and we are dealing all the time with type 3 severe infection with gap, deformity, shortening, and everything. Now, non-unions are, that I told you, radical and thorough debridement, compression of non-union by Ilizarov fixation with lengthening or bone transport, conversion to internal or hybrid fixation in less severe infection, and augmentation of healing by bone grafting. This one, last one that I told you, I have never done in my life till today. And even some of the orthopedic surgeons, they are doing. These are the following factors important in the management of non-unions, the radical debridement, first and perhaps the most important part of the management. And how to do that, you know, these are the things sequentially. You should have to remove loose implants and resecting centimeter by centimeter, and you will get the punctate bleeding that we call the paprika sign, and removal of the nephrotic tissues. If you have intermediary canal, you should remove that one for removing the debris and excision of the scarred and infected soft tissues, and repeated debridement. Sometimes it needs 2 or 3 days under generalized anesthesia. Fracture stability is very important at the time of radical debridement. Ilizarov fixators are ideal because internal fixation that we are doing for intermediate nailing or plates can cause further devascularization, which will lead to aggravation of infection. Soft tissue coverage, sometimes do that, and preferably plastic surgical procedures to cover the bone should be done after 8 to 10 days when wound is covered with healthy granulation tissue. bone grafting that I told you, implant removal. Now, regarding the treatment of infected non-union type 1, if you look at this, in our experience, functional cast has given excellent results. Patient is forced to work as much as he can. If there is a loose implant, plate or nail, it should be removed. The cast is changed after 4 to 6 weeks. X-ray are taken if necessary. Cast can be reapplied, and single alternative is to apply external fixator immediately. And type 2, see, non-union is treated by Ilizarov method because it simultaneously addresses all the problems of type 2. And type 3, this is best treated by Ilizarov technique because here you will get shortening, deformities, gap, infection, everything which can be treated by fantastically by Ilizarov technique. Again, if you think about the type 3, it is divided into 3 groups, 3A, 3B, and 3C. A, there is no gap but deformity or shortening. If you wish, you can treat this by Ilizarov or other technique. And type 3B, complete defect of all circumference of the cortex with large wound. This is best treated by Ilizarov. And incomplete defect with partial circumference, also you can treat by Ilizarov. Now, what are the problems of INU, infected non-unions, that I told you earlier? And I want to add this one. See here, the sinuses, osteomyelitis, bone and soft tissue loss. You will get the fibrosis, osteopenia, skin problems, adjacent joint stiffness, complex deformities, limb length inequality, and multiple resistant polybacterial infection. These are the problems of the INU. Now, based on this, a few basic principles we must know. Sometimes you need to go for biopsy culture. All necrotic and non-bleeding bone must go undergo debridement. A high-speed bar is used to debride the bone, and the continuous cooling irrigation is applied to the bars. And tibial cortex experiences very little bleeding. We must look for the paprika sign that I told you earlier. Now, which one is very important? Ilizarov effect and law of tension and stress. You see, dear friends, before Ilizarov, there was the invention of rings, but the biological parameters and law of the tension and stress, which is described by academician Ilizarov, slow and steady traction on a living tissue creates a stress which is metabolically activated in both the biosynthetic and proliferative pathways depending upon the vascularity and the functional use. Professor Ilizarov in 1983 showed that blood supply after applying the Ilizarov increased 330%, which was a research work by applying the apparatus in the docs. And treated infected non-union is a challenging problem for most of the orthopedic surgeons. And what I should tell you, Ilizarov is the best fantastic tool which can treat, which can be managed by this fantastic tool. Now, corticotomy, you know, common mistakes during corticotomy. Corticotomy is very important. This is the part of the Ilizarov surgery. Too large skin incision, poor choice of corticotomy level, uses of oversized osteotope, destructive hammering of the cortex, direct cutting of the bone marrow canal, injury to nerve vessels and nerves, performance of twisting corticotomy maneuver before complete cutting of medial or lateral cortex, and sometimes you can do the incomplete corticotomy and traumatic corticotomy. Sometimes if some surgeon is not expert, then he may do this kind of traumatic corticotomy. Now, dear friends, I'd like to share some cases, difficult cases with you. Before putting the Ilizarov apparatus, you must know the safe corridors. Within a short time, it is not possible to explain you everything all the time. If you are expert with the Ilizarov technique and the apparatus and the methodology, you will be able to apply the Ilizarov the proper way. Look at this in the humerus. You must know this is, you'll see infection, loosening, Then what I have done, applying the apparatus, only the wires, playing with the wires. Look at the right side, radiographic view with Ilizarov apparatus. And it is during treatment, after removal of the apparatus. Now you can see after only 4 months. So this is, you can see radiographic view, final follow-up. Again, the safe corridor. This is very important also. Look at this infection, the right side, see. These are the cases that if you know the principles and the philosophy of the Ilizarov, you can have a very good result and outcome with this kind of, which was applied before plate and screws. You just remove. I put the guide wire inside, only the K wire is moved, and see the only playing with the wires and the olive wires. And this is after removal, after treatment. See again, that's the 3A. He was treated elsewhere, infected non-union long bones. This is the ulna. This is again wire incision. You must know the safe corridor. He had the same time at the on non-union also, femur also. Now you see 4 ring constructs with the wires. Then I have done the corticotomy and gradual lengthening. Now you can see here from this after 1 year follow-up to the big long gap. So again say non-union, which is treated by the rationale, lady, forearm. Now you can see here again playing with the wires and the olive wires and the smooth wires. So this is the final view from this situation to that situation. Deformity and the non-union with rationale. You can see here. Say again in the proximal femur, you must know all these things. Whenever you are applying the Ilizarov in the femur, lots of orthopedic surgeons, they are telling all the time, this is cumbersome. I must tell you, cumbersome for the, not for the surgeon, cumbersome for the patient or surgeon. Now see, this young gentleman, 35 years, he was treated with gentamicin bits and at the same time with interlocking nails. So infection was, bits did not help. Then he came to my place. I have removed everything. Only in the proximal part, I put the shants, and you can see here in the middle and distal part, this is with the wires, smooth wires and the olive wires. This is after 7 months, and this is after 5 months follow-up. Look at this from this situation to that situation. So these are the case. Again, you can see which was treated by plates and screws, bulky, lady. Look at the thigh, very difficult, bone quality was not good. There was a discharging sinus. And then after removal, clinical appearance of the patient, this is after 5 months follow-up. Now we can see this is after 8 months from this situation to that situation. If the patient is obese, sometimes it is very difficult to treat this kind of patients. Look at this. I have a bitter experience of this gentleman from Somalia, 130 kg. He was treated 18 times in different countries, in Somalia and Uganda, and then in Singapore, in Germany. Then he came to my place with 130 kg. Look at this thigh. He's the teacher. He's a teacher. Then during treatment with the Somalian, look at this. If you look at the apparatus, you'll see that it will look like a very clumsy, but look at this, what I have done. So these are the shams, and I put multiple console wires. These are the console wires, and gradually, console means from one cortex to another cortex, don't pierce the second cortex. And gradually you just pull these wires. As a result, you are increasing circulation in the whole limb. And what happened, you can see. And after 6 months follow-up, this is before, and this is, you can see, after 6 months follow-up. 6 months follow-up. Though, so 18 times he underwent surgery in different places. And this is the man who is a teacher of the university. Send me this video. He's calling me as a hello. So this case, now dear friends, I'd like to share this case with infection and osteomyelitis. See the discharging sinus of a 3-year-old boy. I have done nothing. What I have done, just I put the apparatus. After 2 months follow-up, you see, with the wires. This is after 3 months follow-up. And this is, you can see here, first step surgery, radiographic view with CAFO. This is after 5 months follow-up. Look at this. I told the patient, after applying the apparatus, you just bear the load and walk, load and motion. And this is after 11 years, you can see from this situation, pathological fracture, discharging sinus, and this is after 11 years. Then again, patient came to me for second step surgery. I did this lengthening in the tibia and the femur. Look at this. And in the tibia, always I put the wires, not any pins. In the proximal femur pins, now full correction, 12.5 centimeter LLD. Then you can see from this situation to that situation, this is after 12 years. So dear friends, so Ilizarov, in this kind of patient, there is pathological fracture with osteomyelitis, the long bones. You don't need to open, and you can treat nicely with this kind of Ilizarov apparatus. The more difficult the case, more is the Ilizarov. Ilizarov keep you safe, planned it to realign, and preoperative planning. See, the power of planning is very important. This is the case. Young boy, 17 years, situation in a baby taxi, you can see here. This is the bone. After 7 days, he came to my place and told me, doctor, this is my bone. Can you put this one? See? And in our another place, advised him to go for imputation from here, 26 centimeter. Look at this, 27 centimeters, sorry. And then I have just seen the vessels are okay. Fortunately, the vessels are okay here. And he had the same time in the ipsilateral tibia, also ankle, distally injured. Then I have lengthened C bifocal. From here, lengthening fast, and here, these are the cases, challenging cases. Very big gap, 17-year-old boy, and then 7 months follow-up. Now you can see, dear friends, how he's walking. So this is the case. Now you can see the after 10 months treatment from very big, centimeter big. This was, there is a publication, destruction osteogenesis technique for infected gap non-union of the femur in American journal. Now again, safe corridor. Every steps when you go, it is very easy in case of tibia. Look at the concerns, what dribbling pass. This is the case situation. And in our area, in our regions, in India, in Bangladesh, in Pakistan, and this Sri Lanka, or even that in Myanmar, this kind, we're getting lots of cases like this. Dear friends, look at this. Dribbling pass. Then these are the cases that can be best treated by Ilizarov technique. And with Ilizarov, after 4 months follow-up, 5 months, and you can see here from this situation to that situations after 1 year. Look at this, and this is after 2 years follow-up. Look at this, again tibia, safe corridor, you must know, no bones. See, treated elsewhere, came to my place, and I am playing all the time with weights. I love to do that. And before treatment, after 3 months, and this is another case treated elsewhere with devastating injury with uniaxial fixator. And again, you can do something whenever you have Ilizarov in your apparatus and you know the principles, and if you follow the philosophy and principles. Again, this kind of discharging sinus with uniaxial fixator treated elsewhere, all infected cases. See, and this is after the treatment. So, dear friends, again you can see that this is one interesting case. I have put you can see here, these are all the console weight to control the infection. Only 2 rings, and you can correct, you can control the infection after doing this kind of surgery. And another one, you see, very big gap on infection, 28-year-old. You can do the, of course, go for the amputation, and for prosthetic limb you can apply, but the patients cannot. Patients, relatives and patient is not willing to do all the time. Then what we have done, this is, you know, the tibialization. And if you look at this, the segmental fracture of the fibula, you can connect segmental fracture of the fibula, and then you can transport that one by doing the tibialization. From that situation, from this situation, look at this. And this is just after the removal of the apparatus with plaster. Now this situation after only 4 months is 4 months. Also, this was published in American Journal. And the biological and mechanical method, this is very important, minimally invasive. You know all these things. No need of sometimes free or local flap. Demerits, I don't see anything, only the greater large cup. Ilizarov, limitless. And postoperative management is sometimes very important. And I have seen, and we are seeing all the time, the young surgeons, they're applying the apparatus, and they don't follow up the patient. Every day, whenever you apply the Ilizarov, you must follow the stability of the apparatus. So complications, every operations have got the complications. And these complications which you find in Ilizarov, you can easily solve by doing meticulous, intelligent follow-up. And a well-planned step-by-step Ilizarov techniques to cover infected non-union is an excellent method in challenging cases. And you can get the excellent results. Dear friends, the limb deformities, other things, LLD, bony and joint deformities, soft tissue contractures, bone loss, delayed non-unions, infections, transverse distraction, and escaped limbs, you can treat by this fantastic Ilizarov technique. So this is very important for the Ilizarov surgeons. Those who are doing Ilizarov apparatus in the femur, you must have this kind of cut. Otherwise, it is difficult. Patient will get pain, and a special cut to recess is important for thigh. And fundamental principles of Ilizarov methodology is load and motion. You must have very good rehabilitation. You must treat the patient and check the apparatus all the time. See, in my center, I always do, whenever you are putting the Ilizarov apparatus in the thigh, you must have exercise protocol so that the patient can get the early recovery. Look at this, what they are doing. You must tell them, no cumbersome. The cumbersome, whenever you don't know how to apply the apparatus in the femur properly. And these are the things that you must follow, dear friends. Now do what they are doing. You must tell them proper application, the stability frame, and doing the exercises. These are the very important. Whenever you are applying in the femur, in the humerus, or in the radius and ulna, or in the tibia, you must do the exercises all the time. So these are the patients in my center. in every aspect, see all the cases, and the purpose driven law. Challenge is an opportunity. I always tell there are common problems that concern us, the majority in the society at large. So this is, these are my good friends, my teacher, Professor Shipsuf, my mentor, and this period, war in Russia, everybody is telling. But we had a very good time with our Indian friends, Manish, Shamsul, and Amar Sani, Kartik, and see our Tashkent Indians, and Omar Barabi is also there, Professor Shipsov, and Anna Mayorovna in Ilizarov Center. These are all stalwarts of the Ilizarov in 16. And my publications, I always love to show this one, dear friends, because see here, I have done reviewer as a 9 PhD theses, DSc thesis 2, and I have now more than 100 publications, internationals. Said these are the books. Thank you very much. And what I've shown you, this is always, I love to show this one also, evidence, science, and of course, the surgical skill of the surgeon. And you can do it, you can do that. So, and finally, dear friend, this is my last one. I always tell this: peace, perfect endeavor around the countries of the earth. So you can do a lot of things by doing Ilizarov technique. Thank you very much for your kind attention and giving me the opportunity to talk in this forum. Thank you very much again. Okay.
Thank you, sir. Please unshare the screen, sir.
Dr. Bari, amazing, and such a beautiful presentation. I think it shows your work, how many number of cases you do, and the wide experience you have. And really, I want to give him standing ovations. Excellent lecture.
Thank you very much.
Good evening, Professor Novikov, sir. We have Novikov, sir, here, sir.
Dr. Bari.
Yes, sir.
Very, very nice presentation. But I want to know that in one of the femur cases, you have used the console wire.
Yes.
So you can use the screws, tank pins, and other things. Why you have used the console wires?
Infection, console wire, very thin wire, 1.8 or 1.5. You can pull one cortex to another cortex. And gradually you just pull that one up to the first cortex. And this helps to increase the circulation in the whole lip. Even if their skin is black, even in the diabetic patients, the skin will be normal. Discoloration of the skin, it will normal. In Kurgan Center, Professor Klushin, one piece in the world, who was the long time, did lot of things with the osteomyelitis cases. And these console wires, instead of putting the screws, console wires helps a lot. If you pull the console wires, you will increase the circulation in the whole limb, and as a result, you can control the infection. This is the role of the console wire. Multiple wires, and these wires you can put fix to the plates, long plates, and gradually with slotted wires, you just pulled. Okay.
It means you want to say that console wire, because it irritates the bone and other soft tissues,
Exactly.
which increases the vascularity.
Yes, irritation. Whenever you're pulling, you're increasing circulation. Drilling, increasing circulation, and pulling, increasing circulation. 5, 6, 7, 8 console wires is very good in the long bones, especially in the femur, and even tibia also.
Thank you very much.
Novikov, sir, any input from your side, sir? Novikov, sir, please unmute. Please unmute, sir.
Full screen.
Thank you very much, dear Bari, for your excellent presentation. And one more time, you show beautiful possibilities for doctor, for patient, and Magic Ilizarov can help with any situation. And Bari, do you have any difficulties or poor result with this situation? And do you have any patient where you cancel or not support with Ilizarov?
Thank you very much for putting me the good question. See, my topic was infected non-union. Whenever patient comes with infected non-union in any parts of the human body, I feel myself very grateful because I can help, I can do something with that armamentarium, that is the Ilizarov. No other alternative way. This is a long way. I'm treating with all these kinds of infected non-union, all deformities. I love to do this Ilizarov because before doing Ilizarov, I have done a lot of cases by this, normal procedure by plating, interlocking nails. Now I don't do this kind of operations without Ilizarov. I don't feel good, or you can say I don't feel comfortable without Ilizarov. And with this apparatus, Ilizarov apparatus, if we apply properly with flexible Ilizarov wires, then you'll get a fantastic result. Sometimes I face problems, but I must counsel the patient. You may have had this kind of problem, and if you counsel the patient, you will have a very good result. And you must have good contact with the patient. Before applying Ilizarov apparatus, you must tell the patient you will have a good outcome, but you must sincerely follow the instruction of the patients. Whenever patient comes to my place, for every patient, I give an instruction book. I have how to live a life with Ilizarov apparatus. I have written that one in Bengali and in English. And luckily, Professor Gubin, he has taken this book to the Kurgan Center. So what I have written that one. And I have given to some of my Indian friends, this how to live a life with Ilizarov apparatus. You must talk to the patient properly. Otherwise, you'll face a lot of problems with this apparatus. And especially for the femur. Especially for the femur. I love to do the Ilizarov. This is your opinion. A lot of one of my friends from, I tell you, JAYANT Sharma from UK, he never loves to do Ilizarov with the femur. Big gap, non-union, I've shown you what you'll do. Any other alternative way, you just tell me. I've shown you 127 centimeter gap. They decided to one of the center to go for imputation. Now he's happy because I know the vascularity is okay. I can increase the vascularity 330%. It is shown by Professor Ilizarov. That's why the most proper thing is that you must know the procedure and you must love the apparatus. You must love the patient. Otherwise, no. This is my opinion. Thank you.
Dr. Bari, I think stretching Dr. Novikov's question,
yes.
I want to ask that how do you decide that this patient should go for limb salvage and this should not? What is your line,
See, whenever patient comes to my place, I just go for the vascularity of the patient. Doppler machine, I see. Even for this, now I have one patient, I'm telling you. If you see your anterior tibial artery has gone, posterior tibial artery okay, or dorsal split is gone, you're going to salvage the limb because you have the Ilizarov apparatus. Any one of the vessels gone? Yes. If 3 has gone, nothing to do. One, either anterior or posterior, you can salvage the limb. And because shortage of time, I could not show you the cases, the devastating case I have that I have treated with this Ilizarov apparatus by increasing the vascularity. So decision is before going for Ilizarov surgery, I must see the vascularity with this Doppler study. As soon as the patient comes to my place, then we see the, this apparatus we put, whether he has got the vascularity, then we go for surgery. Even if it is open gastro 3B, nothing to be worried. Gastro 3B, flap surgery if you want, you can do. Or one time, if you have the 5 centimeter, you can compress and go for lengthening by Ilizarov. But counseling is very important. Or from young 16, 17, 18, 19, 20, 21 years, you can easily treat Bari-Ilizarov. If 60, 70, that is another thing. But for the young, we must go for all this Ilizarov surgery. And my always earnest request to all the young staffs, those with the budding orthopedic surgeons, Ilizarov surgery, if you follow the principle and the philosophy, you have a very good result. And I tell you, I never used in my life in tibia pins, never, only with the words, playing with the words. Even in the radius ulna, never shunts. In the humerus, upper, sometimes I use, always with the wires. And the proximal femur, 1 or 2 or 3 shunts, otherwise with wires. Thank you very much.
Thank you, Bari.
So one question from me, sir, to Dr. Professor Bari.
Sure.
Sir, for radius, your preferred position of doing a corticotomy?
Yes, for radius, radial tuberosity below that, or distal part you can do. Yesterday I did another one case, this non here, and tomorrow I'll do for that one. Most of the orthopedic surgeons, even the Ilizarov surgeons, they are afraid of doing the applying apparatus in the radius and ulna. I tell you, there is a lot of vascularity, but nothing to be worried. If you follow just the safe corridors, very easy. In the radius, below the radial tuberosity, or the shaft you can do, or distal part you can do. In ulna, same also. Proximally, middle, or distal, whatever you like, depending upon your case.
So my personal experience with corticotomy just below the tuberosity, the fragment, the proximal fragment went into a flexion. I mean, it was going more palmarwards as compared to the distal part. So I was very much afraid of doing a corticotomy in the radius. Whereas in femur, it is always, ulna, it's always very easy and safer.
Even I've shown you the case. You have seen the 3 cases I've shown in the radius and ulna. You can do anywhere in the bone, even in the diaphysis of the radius, distal part of the radius, above the radial tuberosity, you cannot do that. And whenever I do the corticotomy lengthening, I put OLS K-wire inside, so that I don't allow the deviation. I must maintain the axis of the bones by putting the
So you suggest a guide wire to be put in?
Yes, most of the time I put the guide wire. Most of the time in radius and ulna.
Okay, sir.
Right, sir. We have Prasad sir, Vasu sir, Ranjit Barua sir. Any questions, sir?
Good evening, Bari. I have one question. Actually, the forearm, you get more of atrophic variant of regeneration. What is the precaution that should be taken?
You must follow again the principles. Don't open up too much. Don't destroy the periosteum. Just I have a very small, for doing the corticotomy in the radius and ulna, 3 serrated pointed, I have the special, corticotomy, serrated. That helps me to avoid this atrophic type of non-union. Serrated, small, serrated, it doesn't slip, and it holds the bone very nicely. With that, you can do the corticotomy.
I do with giggly saw only, but still I am getting the type of atrophic non-union.
You're getting,
I do
because
you
are using giggly saw, probably that's why. The giggly saw right. You're using, you are creating a bone burn. There is an article written by John Hargenberg.
Okay.
He's written by John Hargenberg. If you do the corticotomy by giggly saw, you are damaging thermal necrosis. You are creating. That's why maybe you are getting this kind of atrophic non-union.
And one more thing, you said comfortable, but it is not only comfortable, but it is a confidence behind you that you can take more high-risk cases of bone transport and regeneration day after day. So that is the confidence behind you for a trauma surgeon rather than comfort.
Maybe. Okay.
Work to take more complicated cases.
Yes, sir. Bari sir and Nariko sir, one question from both of you. We saw at Kurgan that nowadays they are doing corticotomy directly by osteotomy only. Directly by osteotomy, no pre-drilling. What is your opinion about that, sir?
Whatever you like, you do. This is the Ilizarov method. Directly we are doing. Sometimes I do both. In femur, if I see it is stable, then I do a little bit. I weaken the bone by doing the corticotomy, by doing the drill hole, not with the drill bit, with the 1.8 or 2 mm K wire. Then it is very easy to do the osteotomy, you know. I don't open up, I don't open up the periosteum, lift up, never. I always follow the original Ilizarov's corticotomy. Gigliso you can do, you can open up. Most of the orthopedic surgeons I see, even they lift up the periosteum. You don't need to do that. You must respect your mother. That mother is your this periosteum and the bone marrow.
Noviko sir, your view, sir. Direct, yeah.
No, during my life, I make only Ilizarov osteotomy. Many years ago, we prepare line of osteotomy with K-wire. Just now, we use drill bit. And this support us for safe bone marrow. And I am so different result with open fracture with Gigliso, and I am prefer Ilizarov osteotomy because from beginning we can to manage grow in regeneration. And during this presentation, Dr. Bari show Ilizarov effect. Dear colleagues, when we talk about Ilizarov methods, this is very, very, very important. Ilizarov frame, possible plastic. Just now, many doctors use combined system, shunts, half pin shunts, rigid system, pins, K-wires, and Ilizarov methods give us knowledge patient need from first day after surgery, start work activities, but just now we talk about Ilizarov effect. This is procedure. Everything in the hand of doctor. Doctor need to feel how this is regenerate, grow. And excellent. Just now you start to talk about effect. And I think few doctors in the world follow this point, Ilizarov effect, and sometimes we need stop lengthening. Sometimes we need increase speed of lengthening. Sometimes we need change direction of lengthening. This X-ray picture show what we need do. And today, Dr. Bari give us chance to see how he grows. This is regenerate with the Ilizarov effect, 10, 20 centimeters and more than 20 centimeters defect. This is fantastic result. And I am happy today because I am one more time saw Ilizarov effect in Bangladesh. Thank you, Bari. Thank you, Shamsul, for your question.
Thank you, sir. We can see Professor Andre from Kurgan here. Sir, can you hear us, sir?
Andrei Kaminsky.
Hello.
Yes,
Hello,
sir.
Andrei Kaminsky, how are you?
Hi, I'm fine. What
Fine.
makes you and what's the colleagues?
Have you heard my lecture?
Yes, sir.
I haven't lectured.
Okay, thank you. No, you want to pass any comment?
No, I'm sorry. I'm belated. I'm belated. I'm belated. I no see this lecture. I only listen my colleagues. That's all.
Thank you. Spasiba большое.
Thank you.
Shamsul, you must
Yes,
tell
sir.
who is Andrei Kaminsky. He was our teacher in the cadaveric workshop.
Cadaveric workshop.
Fantastic. And he is a total hip surgeon.
Right, sir. We had Professor Andre and Professor Dennis at Kurgan at Jekaterinburg cadaveric course. He's a fantastic teacher. Sir, we cannot see you, sir.
Ваши
Where
лицо
are
не
you,
you.
видно.
Andrei?
Андрей, ваше лицо
Thank
не
you, thank
видно.
Right, sir. So, and we have Dr. Bananoko from Colombo also. Bananoko?
Bananako?
Yeah, please unmute.
From Congo?
From
Yeah,
Congo.
Congo.
Yes.
Yes.
Oh, Bananoka. Hello.
Yeah, hello. Спасибо большое.
Good to see you. So, before we move to the next talk, do we have another question from the panel?
Yeah,
Vikas, sir, please.
yeah. At the outset, I must thank Dr. Bari for showing gamut of cases, which actually stimulate all of us. He has shown very good result. So regarding the corticotomy, I would just like to add that I do giggly saw corticotomy in all tibial cases with equally good results, which I have seen my professor like Dr. Katani, with whom I have done fellowship, Dr. Dror Pele, and there is no difference in the quality of regenerate. In fact, it has several distinct advantages. You don't have to dismantle the frame, and it gives a very clean cut. But having said this, you should be familiar with the principles of corticotomy that are more important rather than the technique. So this is the point which I want to add. I'll probably show the corticotomy which I do with giggly saw, having learned and done in the tibial cases, in all the tibial cases which I do. Thank you.
Thank you, sir. I think we have a question in the chat box from Dr. Praful. Sir, Bari sir, can we use Ilizarov in fresh fractures also? There's a question from you.
I told you, except head. In every case,
Yes,
I do the fresh case. Fresh case, if you do the interlocking nail, you are opening, why not in Ilizarov? You just tell me. From today, you have applied the Ilizarov. From tomorrow, you can tell your patient to work via load and motion. Why not? All closed methods. Everything I do by Ilizarov. You believe it or not, thousands of cases that I have records. If you do for Ilizarov, without Ilizarov, interlocking plate you can do. Why not Ilizarov? You just tell me by simple words.
right, sir. Thank you, sir. Now we can see Professor Andre. Thanks for coming on video, sir. So if you have any more questions from the panel.
Okay. Thank you very much.
So shall we move to the next talk? So thanks, Bari sir, for a wonderful lecture. And
thank you very much for giving me the opportunity to talk with you. All stalwarts are sitting here. Big men. All big men. Thank you.
And thank you. And thanks to all.
Dr. Bari is not bigger than you. You are
thank you. Thank you. You all are good friends. I love all of you.
You are a big.
Whenever I see all these faces, Agrawal, Manish, or Andrei Kaminsky, Novikov, Huda, Bananako, all friends. I love to see all these faces all the time. Thank you.
Thank you, sir. Moving on to the next part. Next, we have a talk by our loving Professor Manish Dhawan, sir. So, Professor Manish Dhawan, sir, is a senior consultant in orthopedics at Sir Gangaram Hospital, New Delhi. He's a professor at GRIPMER, that is Gangaram Institute of Postgraduate Medical Education and Research, New Delhi. He's a teaching coordinator at GRIPMER, at Examination National Board, chairman of Clubfoot Committee, Rotary District, and past dignitor is past treasurer of Indian Orthopedic Association, past coordinator Indian Orthopedic Association PG training program, past president and past vice president, past secretary and past DC member of Asami, India. Secretary of Rotary, Director Community Service at Rotary Club Delhi South. And regarding awards, he's got Honorary Fellow of Asami India, Russian SCB Medallion for Deformity Correction, Best Rotary Award, Rotary Club Delhi South, and Diamond Secretary, Rotary District. Today he's going to talk on aseptic non-union. Over to Minister.
Thank you, Dr. Shamsul, for such a beautiful introduction. Can you hear me?
Yes.
Yes, loud and clear, sir.
Yeah, actually, my task has become very difficult after speaking after Dr. Bari, because his experience, and actually we follow him also because he has such a wide experience that I've learned so much from Dr. Bari. And recently I had visited Russia also, Bangladesh, so I could see so much of variety, and Ilizarov is a learning thing. I've learned so many new things and I've changed my techniques also. So I work in this hospital. This is Ganga Hospital. It is in New Delhi. Now, I have to acknowledge a few books which I have consulted, and also I've consulted Dr. Bari's book. So this is the last one, is the Color Atlas of Limb Lengthening, which I have consulted. I have consulted all the standard textbooks. So before we go and understand, because Dr. Bari has explained you about the infected non-union, but there is something known as aseptic non-union. So let us now first learn about principles, how to manage them. There are some differences which will go, so we have to go to theory first, and then I show you the cases. Now, first definition Dr. Bari has already given, and non-union is established when a minimum of 9 months have been elapsed since fracture shows no visible progress signs of healing. So this Dr. Bari has already told you, and this you also say delayed union if it is less than 5 months, and Federal Drug Administration panel has given this definition. Now there is one term known as aseptic non-union, and non-union without infection is aseptic non-union. And what is Zood arthrosis? Because this term comes very often, and it's a non-anatomical joint formed between two fracture ends with a synovial fluid. So these are the definitions which come very frequently in when we describe about non-union. So Dr. Bari has actually shown this slide, and he has explained about everything, but I want to make a point that it is not the bone which is important, it is the soft tissue also which has to be given due consideration. So inviable soft tissue, bad skin, and the tissue between the bone ends, inadequate local blood flow, infections, or Dr. Bari has already talked, muscle atrophy. Muscle is very important. So you have to give due diligence to every part. Joint stiffness, if you are treating a case of non-union and your joints, adjacent joint become stiff, then your purpose is not there. So purpose is defeated. So arrest of callus formation, bone defects, extremity shortness, osteoporotic bones, deformity, and malalignment. So Dr. Bari has already explained this thing. So with this, then we move forward. Now there are different classifications which cause a lot of confusion. So let me go to the widely accepted classification, because every classification has a message. So classification basically have academic value, but let us go through what is there in the literature. So for very widely accepted classification is Weber and Czech classification, which was given in 1973. And he has explained, he has divided arthrosis into two types, hypertrophic and atrophic. So hypertrophic, he has given 3 types. This is one is the elephant foot, where the bone end at the fracture non-union side becomes thickened. The diameter is more than the normal bone, and it is rich in callus. It occurs when there is inadequate fixation, premature weight bearing. But there is a viable tissue, the viable fibrocartilage, and there is a pseudo joint formation. So the treatment differs in all different types of aseptic non-union. The second type is horse hoof, which is basically a smaller version of elephant foot. It has a poor callus, failed or unstable osteosynthesis with plate and screw gives this type of horse hoof type of variety. So with plate and screws, it has a silent callus which never transforms into fixed callus. So this part never transfers, unlike the hypertrophic non-union, which is a viable callus. This is a dead callus. There is another type of hypertrophic type, zoodarthrosis, which is known as oligotrophic. And this is basically no callus formation. And there is a, if you stabilize with a plate and screw and you leave some gap, this type of situation occurs. So when the fracture is not very much compressed at the fracture site with the internal fixation, you get this variety. Now we come to atrophic zoodarthrosis, which has 4 types. One is the torsion, fragmented, defected zoodarthrosis, and atrophic zoodarthrosis. So in torsion wedge type, we encounter this thing in many cases where there is a butterfly fragment. So blood flow is affected in the intermediate fragment and no stable bridging, and fixation by plate and screw can cause it. Like this can, plate and screw, if you do not give a proper stability to this fragment, so it can go into non-union. And if this is a displaced, the fragment, the extra fragment, the third fragment, and it is due to the increased combination, and it increases the risk of non-union. Plates can be broken due to overloading if weight bearing is started early. So if the fixation is not, the healing is not occur, and patient does an early weight bearing, you have this variety, and it fails. And there is no callus formation, and there is a defected zoodarthrosis, and there is a gap, and there is an absence of part of the diaphysis seen in tumor, infection, bone resection surgery, and it will transform ultimately into atrophic non-union. This is the atrophic zoodarthrosis. This is the worst type. This is the worst type, and it has osteoporosis and atrophy of the fracture site. There is a shortening of greater than 2 centimeters. And stabilization with biological stimulation is required to treat this type of non-union. Now, Professor Ilizarov had given his classification. This is the first classification, and this is the loose type and stiff type. So movement and angulation is more than 7 degrees at zoodarthrosis site and shortness of more than 2 centimeters. Atrophic look on X-rays. Biological stimulation required with stabilization means you have to compress the fracture site and also do corticotomy to stimulate the bone. So the loose type, the treatment pattern is different. Now the stiff type, the movement of angulation is less than 7 degrees at the zoodarthrosis site and shortness is less than 2 centimeters. This is basically the hypertrophic or the elephant foot. So compression and distraction force at the fracture site will cause healing, because at the hypertrophic, the elephant foot type, which I have already told you, there is a viable callus, there is a viable fibrocartilage. So you compress first, crush the non-union, and then start distracting it. It will go into healing. You don't require any bone graft or anything to do extra for that. Now, Pele has given his classification. It's basically the same type. Just to complete it, I'm showing this thing. And zoodarthrosis is less than 1 centimeter bone loss, and he has categorized into A1 and A2 types. One is the loose type, and one is the stiff type. And the stiff type, one without deformity and with deformity. There is another type of zoodarthrosis where there is a gap, and he has divided into 3 types: bone defect in all of them, whether there is a shortening or there is no shortening. Now coming to Katani classification, which I follow because it gives what to do in a treatment. So he has basically, you have to understand that non-unions are 2 types, either lax or stiff, and stiff can be with the deformity or without deformity. So classification based on clinical and mechanical properties rather than radiographic appearance, it helps in determining the type of operative intervention. Means the classifications have academic value, but you should know what you have to do, which method of treatment with Ilizarov you have to do it. So that basically should be in your mind. Ultimately, you have to give the result. Now, coming to lax non-union. So for your practical purpose for surgery, lax and stiff. So we first come to the lax non-union. This is the atrophic type. This has a less inherent mechanical stability, radiological, avascular, poor callus formation, and minimal surface contact. Tissue between the non-union is amorphous, fibrous material, and little potential for bone repair. And instability and lack of vascularity causes it, and loss of vascularity is also caused by infection. So this is my very old patient in 2004, which I treated. You can see the atrophic bone ends, and he was walking on a Thomas splint for almost 4 years. So this will never unite. So stiff type, there is exuberant callus, large area of contact, tissue at the non-union side is fibrocartilage, capable of bony metabolism and bone formation with compression. So you have to compress, crush the non-union, and then you go in for distraction. Instability of fracture site is the cause. If you have gone to treatment, the area is unstable, it can go into hypertrophic. And Ilizarov research demonstrated that compression distraction force provide mechanical stimulus for bone formation. Now, biomechanical principles of treatment. Stiff non-union, you have to do a continuous compression, stable compression without bone graft or corticotomy. You don't require any bone grafting, just if you give a compression, continuous compression, as Professor Ilizarov, this is Professor Ilizarov's word, and this is monofocal intervention at the fracture site. When you are only, concerned about the fracture site, this is the monofocal, the definition of monofocal. Now, lax non-union, you have to give a stable fixation with biological stimulation also, means this is bifocal. Once you are doing at the fracture site compression, or also distracting at the corticotomy site, so you increase the vascularity. So this is the treatment where there is no deformity in the bone, but you have a stiff non-union and a lax non-union. Now, what are the indirect reduction methods? So stiff non-union, you can distract this thing. This is the stiff hypertrophic type. You can put a hinge, and you can, if you distract it, it will go into union. Now, if you can just, these are with plain wires, you can use olive wires like 3-point fixation, 2 olive wires at the end and from this side and 2 from this to pull the fragment, and you can apply a hinge and distract it. Now, stiff non-union correction by olive wire alone. So this is the olive wire alone compression. You can do it in this way. Means you are not basically applying the hinge. You can basically do it. You pull the fragments. If the non-union is not very stiff, so you can pull it. You don't apply hinges. You can put 2 stiff pins, and you can put it. You can have a distraction mechanism here, and you can correct this deformity in this way. Now, if there is a, there is a translation, so you can have an assembly like this, and you can pull both the fragments towards each other. So this is a translation type and how to treat that. This is the oblique compression type, means you have to compress it. So you put the hinge at the neutral hinge and just distract it, so the bone will reduce and non-union will get treated. These are all basically not the atrophic type. These are basically the type where there is, you feel that the bone ends are viable. This is the oblique distraction type. The fracture is oblique. You can have an assembly like this, and you can just distract it, and you can treat the non-union. There is no requirement in these cases for bone grafting or any corticotomy if you feel the bone ends are viable. Now, if coming to the bone loss, Katani has given bone loss with limb shortening, without limb shortening. So you just compress it. Shortening with fragment, what you do that you do the compression and do the corticotomy, and shortening with segment with a bone gap and no contact of bone. So you can do the transport. So treatment of bone loss without shortening is a bifocal transport. Dr. Bari has beautifully explained about it. So you do 1 corticotomy and compression at fracture site and 1 corticotomy. It is known as bifocal transport. So this is animation. It works on best works on a single rod, and you just the rings at the end are fixed rings, and this ring is mobile. So you can transport a fragment. Similarly, you can what you can do that you can do the compression at fracture site, and you can distract it at other levels. So the assembly is different. It does not work on a single rod. It's better to have 2 different units. Now, trifocal transport. If you have 2 types of corticotomies, 2 sets of corticotomies, and then the fracture site, so it becomes trifocal. One side is compression, is the monofocal, then bifocal, and then trifocal. So these 3, and you are working at 3 sites, it is a trifocal. So this is a trifocal transport. You have corticotomy is at 2 level. Now there is another technique where you use the crossed olive wires and which acts like a rein of the horse to direct the bone. So you pull it with the olive wires. Now frame application technique, shortening with bone contact, bifocal frame can be used, shortening with bone gap, trifocal method can be used. Now there is a concept, sometimes in literature you will find internal lengthening and external lengthening. So what is the definition of internal lengthening? Regeneration of bone to fill the gap without change in overall length in the limb. Like there is a stiff hypertrophic non-union, you first compress and you distract. So that is basically, if you want lengthening, it is the internal lengthening. External lengthening is to regeneration to restore the limb length and soft tissues. Basically, there is a gap non-union and you do the transport and then you lengthen it. So it is known as external lengthening. So there is a, I use this technique. This is a chipping technique with Mashuta Takashi has, basically described this thing where in a stiff non-union, you can just make a small incision and, do the chipping of the bone around the non-union with a small osteotome. So in this, I do it in certain situations and you don't require bone graft. So we will also see in the cases. Now, case 1. This is a 37-year-old female, sustained fracture of lower tibia and fibula. Plating of lower end of fibula and metaphyseal plate in tibia was applied and patient went into non-union with implant breakage. Removal of plate and excision of non-union, proximal corticotomy and Ilizarov fixator was applied. Now see the situation. There are 2 plates applied and I took the history of the patient. It was a well-fixed thing, but the problem was that there was some gap at the, the surgeon could not compress it. And I asked the patient gave a history that, I started early weight bearing against the medical advice. So this was her situation. There was no infection. So what I did, I excised the non-union. I stabilized the fibula with a intramedullary wire. Dr. Bari has shown this thing in upper limb, this thing, but it is very useful. You can put an intramedullary wire in the fibula. And then it is better to excise the non-union. I excised it because it was a atrophic type. And I did a proximal, it requires bone stimulation. So I did a proximal corticotomy and did a bifocal transport. So this is this thing. And it went into union with the transport. And you can see the union. And she is fine. We can see a video also. So this is basically, I took 5 months to remove the fixator. You can see her walk. So you have to see that if you are doing internal fixation, your fracture end should have a compression. You should also explain the patient carefully that when he should walk, and you should explain the patient that unless you tell them, they should not start walking. Now, case number 2, this is 22-year-old sustained fractured distal tibia and fibula. Close internock nailing was done. Fracture goes into non-union. Then surgeon, what he does that he keeps the nail inside and then he reinforces it with a plate and did a bone grafting. Fracture still failed to unite and it was referred to me. I did the removal implant. Ilizarov fixator was applied with compression of fracture site and it went into non-union. So this is a young boy and you see that first he did a nail and then it went into non-union and then he reinforced it with a plate and then put a bone graft. Now the issue is that if your mechanics at the fracture sites are not good, it will again go into non-union. So it was a very good fixation, but it went into non-union. So what I did that I just removed everything and just did a continuous compression at the fracture site, like what Professor Ilizarov has told. I was planning that I will see what happens with continuous compression and I might have to stimulate. If it does not work, I'll do a proximal corticotomy and some distraction. but limb length were equal. But to my, surprise, which I was thinking that I will do corticotomy, it went into union. So this is the situation. This is the patient with the frame. You can see his knee bending. And you can see his now, it is after removal of frame. See how well he's walking. So the message is that if you are doing internal fixation, it is very easy to apply, put a plate or apply a nail, but you have to follow the biology. You have to respect the biology so that these complications don't happen. Now coming to case 3, this is a 50-year-old man with comminuted fracture, Gustilo grade 2. So this gentleman had a very comminuted fracture and he had a small wound and he was treated with plaster and dressing. At 2 weeks, the infection healed, but the fracture was so much of comminuted that the surgeon put him in a plaster for 4 months and he did not know what to do. So he was referred to me and now this was the situation. There was no infection. And you see the multiple pieces lying, and it is very difficult to fix this with a plate, and because if you go inside, you will all devitalize these fragments. So situation when I removed the plaster, there was a kind of a deep dermal area of defect, but there was no infection at all. So this thing is the same wound, which is basically a deep full thickness. So I took a plastic surgery opinion. They say that just leave it. It will go by on its own. We don't have to require to do any plastic surgery procedure. There was no infection. So what I did that instead of basically touching these fragments, I just left the gap and I did a proximal corticotomy and started transporting. Now the mistake which I did, I transported in LRS. I should have put a Ilizarov and I could have used for the transport a spatial correction, but I just transported it. The fracture united, all these fragments, they acted like graft and they became a solid union. But the patient had a residual valgus deformity. So I told him that, I will correct it because I used an implant which was a monolateral. I could not correct the deformity. But patient says, no, sir, I am very happy because I was not walking. I used to walk on plaster. So he is happy. He does not want the correction which I have told him that I will correct your valgus, but he does not want it. So I did not touch the comminuted fragments and I just did a corticotomy and transported it. So this is his, X-ray after 1 year. You can see this thing. Case number 4, this is a 20-year-old patient, had a subtrochanteric fracture and it was treated at the age of 10 years with traction. So this was old. So when it was treated, he again had a refracture and he was referred to me somewhere 10 to 12 years back. So I applied LRS and I did not do any corticotomy, but the patient's parent and the patient did not tolerate the orthofix and they forced me to remove it early. So the LRS was removed. It on the X-ray, I felt that it is united, but it was not a proper this thing, and he developed into stiff hypertrophic non-union. Then he came after to me, and then I applied Ilizarov, did a distal corticotomy, and the hypertrophic non-union went into union with compression and distraction. And I sorted out the limb length discrepancy, and he came to me almost after 6 years. So this was the situation. He had he was treated in the childhood by traction. Then he had a fracture. Then I applied this thing and I felt that this is united and they forced me to remove it early. Then it went into hypertrophic non-union. You can see this is elephant foot type. This was the situation. I applied Ilizarov, gradual compression and then distraction, did not bone graft this area, did a distal corticotomy. for limb-length discrepancy, and it increased circulation and went into union. Now this boy comes to me after 7 years. This is the situation. We can't make out also that he had 3 times he had surgery. Now, case number 5, this is a 5-year-old boy who came to me with deformity right ankle. He sustained a run over by a motorbike wheel, had stiff non-union just distal to the distal tibial epiphysis. Non-union was freshened by the same Japanese chipping technique. I made a small incision and just distracted it with the hinges. So this was the situation. And I just, because it was so near the epiphysis, I just opened from here and just did the chipping and distracted it, and it went into union. Now coming to case 6, this is a 23-year-old motorbike accident, had a segmental fracture tibia, initially treated with plaster, then plating was done. Developed hypertrophic non-union at lower side, chipping of non-union site, and proximal corticotomy and LRS orthopedics application was done in 2017. So this boy, he is a medical student, had a fracture, upper part, and this was a segmental fracture. So there was a union at the upper part, but this was a non-union, which was basically he used to not be able to walk full wear weight, and he could not run, but he was walking. So what I did is that I did the chipping technique. I chipped this whole thing. You can see I've done the chipping here. I did a proximal corticotomy. And you can see I did distraction was done for limb length. And now this boy comes to me after 7 years. This is the situation. I just took this X-ray of, almost, you can say after 7 years. So this is basically the fibula is distracted because of the lengthening. This is his when LRS was there. Now he has come to me again, and he's fine. Now this is a case 7, a non-union distal tibia fracture after failed internal fixation, excision of non-union and bone transport was done. Now this 51-year-old overweight woman sustained closed fracture lower third tibia and fibula. She was crossing the road and had a run over by motorbike. Internal fixation first was done by anterior lateral plate and later reinforced by small locking plate. Went into non-union and referred to me for Ilizarov fixation. Now this you can see is a very benign looking fracture which we encounter in ours. So just putting internal fixation with 2 plates could have done this thing. But what happened? Surgeon just applied the anterior lateral plate. He did not address the fibula. So what happened that it went into non-union. So patient came to him. So what he did that he did fiblectomy here, and again put the screws, retained the same plate, and put a extra plate on the medial side so that he has reinforced. But again it went into non-union. So for me the option was to excise, move everything, excise everything. Did a proximal corticotomy, applies the Ilizarov frame. This is the patient with the frame, and this is the proximal corticotomy. See, the fracture went into a union, and this is her X-ray. Now coming to case 8, this is a 43-year-old male, had a fracture lower third humerus with a butterfly fragment. Dual plating was done, fracture went into non-union, and later breakage of both plates. Basically, the history is that everything was fine, and he had a fall, but he did not take an X-ray and continued. But what he realized that after 1.5 months, the elbow started having the deformity. So patient was referred to me. I removed both the plates and Ilizarov was applied and healed with compression with the fracture site. This was his first X-ray. You can see 2 plates. So much of metal work was done. I think they have totally removed all the periosteum was elevated, and you can see it was already a non-union. Then he had a fall. The plate started bending. So I removed everything, just compressed at the fracture site, and you can see This is the frame. And you see the union. This is the X-ray of the day when I remove the frame. It's after removal of frame immediately. Now his elbow movements have improved and have become almost normal. This is the day of I removed the frame. Now case number 9, this is a 30-year-old male, had a landmine blast injury with injury in the both lower limbs. He is from Afghanistan. So he had multiple surgeries and multiple flaps, and he came to me. Now this was situation. Now problem with me is that this is a split skin graft. I could not open, and no open surgery could have been done. So he used to walk like this. So they referred to me. What I did that I just, because the fracture, the non-union are very near to the ankle, I just did the chipping here and just distracted it with the SUV frame, and it went into union. This is the situation. So thank you very much. And my cases, I think, are less in number than Dr. Bari because he has a very wide experience. But yes, today the talk, I think you all would have an understanding that what is the modality and how we apply Ilizarov in aseptic non-union and how in infected non-union. So aseptic non-union usually you find with failed internal fixation. Thank you very much.
Thank you, sir. Thanks a lot for a wonderful introduction, sir. So now we invite our panel for the questions.
Now, how do I stop share, Shamsul? One
I've done, sir. I've done for you, sir.
Okay. So no question means anybody has question?
Doctor.
Agrawal sir has a question.
Yeah, actually, it was a very nice presentation. So you are one of the case who was having the near the fracture of the refracture of the proximal femoral near neck. So because the cause of the fracture was varus deformity. So second time you have operated that, but still there is a varus deformity exists. So I mean to say that it can refracture.
No, Ilizarov, I have corrected the deformity. No, sir. This is my learning case because this is almost, see, this is early in 2004 something because I just, didn't have much experience. But what orthofix failed. Traction, then orthofix failed. Then I went into Ilizarov and with corticotomy and I corrected the deformity.
Thank you.
Dr. Ravi, we can share this case later. This is case by Dr. Rafi.
I must first comment regarding the Manish Dhawan's lecture. Can I talk?
Yes, sir. Yes.
Yeah, very good, Manish Dhawan.
Sir, we lost your voice. Dr. Bari, we lost your voice.
No.
Now it is. Yeah, it's coming.
Very good lecture. Very good lecture.
Thank you.
A lot of learning things here. But one thing is that the hypertrophic non-union is, we know always that this is the callus is very good, but mechanical stability is that is poor. That's why mechanical stability is needed. And you showed in one case very good. I like that one with shortening. You just compress and you have done the lengthening. So the teaching for the budding orthopedic surgeons, you don't need to touch the hypertrophic union. Most of the surgeons, even in my country, see, they opened it, clean it, myriads of callus are there, only lacking of the mechanical stability. So that I liked your that one, that you showed hypertrophic with shortening. Go for compression or accordion method, and then go for lengthening without doing corticotomy. Also, you can have the result with correcting this shortening and union at the same time. Compress fast, then you can go for lengthening without doing corticotomy. Okay?
Yeah, thank you, sir.
Thank you.
Manish,
Yes, yes. Good evening.
you were mentioning continuous compression in non-union, hypertrophic non-union.
Yeah.
Suppose the patient is on the frame for about 4 months.
No. See, continuous compression, what it means that I will not compress 1 millimeter per day. I will do, suppose for 10 days, I do half a, quarter, or, 2 quarters. Because when you compress, what happens? You keep on compressing, the patient starts having pain. At that point, you have to stop. This basically not the continuous compression that we give it compression for 4 months. It is basically to crush the non-union. Once you crush the non-union, you can even go in for distraction. So it is a continuous compression, not in a low, frequency for few days till the patient gets pain or he is uncomfortable or his legs become heavy. So this is the point. It is very well crushed non-union. You stop it. This basically is Professor Ilizarov's technique, which I have followed from his book, and it works.
When you say continuous compression, there must be a limit.
Probably I should have written in my slide, but actually is this. So but it works in hypertrophic. It works. Compression and distraction. Basically, you can say that it is part of accordion. You compress and then distract and stop and then compress, distract is something like that. Because when you compress the non-union slowly, what happens? The piezoelectric currents, they start developing in the fracture site. And these are the currents which stimulate the fibrocartilage to make the bone.
Hello.
Yes. Hello.
Hello. I'm Dr. Borwa from Assam. Can I just ask? Hello.
Yes,
Can you hear me?
sir.
Yeah. You said about compression. You said that it is 1/3 two times a day or half a turn 2 times a day, something like that. Can it be 1/4 of a turn every 3rd day till the fracture unites?
No, it is basically for non-union. Basically, this method I've actually missed in my slide. I have to put a line. See what happens that you have to crush the non-union. So what you have to do that you have to do it slowly, and maybe for 5 to 7 days or 10 days, then patient starts having pain or uncomfortable. Then you at the point you stop. You can do it 1 millimeter per day also, but then it will be slow. I mean, means it will be very fast. So you can do that also.
Basically, you produce an inflammation at the non-union site.
Yeah, if
you
crush the non-union,
continuous compression.
Yeah, because it's a fibrocartilage, it's a viable. So when you crush it, what happens? The piezoelectric currents, they surround the non-union site, and these are the currents which stimulate the fibroblasts and form the bone. This is basically researched. This is the research on dogs.
Okay.
Shamsul?
Yeah, any more questions, sir? So shall we move for the next lecture? So since we're having late...
For the youngsters, when you're doing an Ilizarov frame, because Ilizarov is an instrument by which you can force the non-union to heal, as well as you can correct all the deformities. So at the end, you must always see that the axis is well corrected. So don't try to accept any deformities. At the right moment, try to correct all the deformities into a fully aligned normal-like bone, which is quite possible. We are spending some time on that.
So thanks lots of Vasu sir for your valuable feedback, sir. So now, since we're getting late, I request our esteemed faculty, Dr. VIKAS Gupta sir, for his presentation. Case discussion about non-union. VIKAS, please.
Yeah, I'm sharing my screen.
Yeah, sir is a professor at Southern Hospital.
Is it visible?
Mm.
Am I audible?
Mm.
Okay.
Audible, yes.
So,
Hey,
good evening, friends.
wonderful.
And I think my job has made easy by my predecessors, Dr. Bari and Dr. Manish Dhawan, my good friend. So, I'll be speaking on bone transport in infected non-union tibia. And in fact, this model is one of the oldest model, in fact, kept in a museum in Russia, where Ilizarov used this technique, his indigenous device. Now, coming to the talk, infected non-union of the tibia are easy to diagnose, but very difficult to treat. We all know. We have the challenges like bones which are osteoporotic, sclerosed, infected implants, draining sinuses, and as well as over and above soft tissue comprised due to multiple failed surgeries. And patient is financially as well as psychologically drained. In fact, they're very depressed. So we have the options like massive cancellous bone grafting, vascularized transfers, fibular transfers, or masculinate-induced membrane technique, which I think non-Ilizarov surgeons are doing it. But I think those who are trained in Ilizarov can vouch that it can correct multiple elements of pathology using the technique of bone transport, bifocal, where you have activity at the two level, a trifocal for a large gaps, and for acute shortening, like smaller gaps less than 2 to 3 centimeter, we can have monofocal lengthening where compression is done at the same time, and the subsequent lengthening which is done, which is called a monofocal. And I feel amputation is no longer an option in the present era. So what is bone transport? Actually, how to define it? It's gradual translocation or a movement of a segment of bone from a healthy area into region of bone loss by creating a low energy osteotomy outside the zone of pathology and using an external fixator to transport this bone fragment under controlled mechanical conditions. And we follow the principles of biology, the destruction, osteogenesis. So if you see this photograph, it moves like this. You have created a corticotomy and created 3 segments, and the middle transporting segment is moved until it docks with the parent segment, and you have the regenerate. Now, it follows if you are treating a patient with infected non-union of tibia, you have to follow the steps of preoperative planning, operative steps, and be aware of the post-operative problems or challenges you might face. So preoperative planning, you do it with a radiograph, which is a blueprint for planning and making a frame. So you know the extent of bone resection. You can plan your level of corticotomy, either proximal or distal, as well as you can plan the bone transport. It has to be antegrade or retrograde, depending on the larger bone segment. The pre-construction of the frame saves operative as well as anesthesia time. And you must remember, after corticotomy, you have created 3 segments: a proximal segment, a distal segment, and a middle transporting segment. And all these segments should have at least the principle of ring block. You have 3 independent segments which should be adequately stabilized, ideally with a ring block, that is 2 rings. Now, the debridement, which has been now stressed number of times, remains the cornerstone of treatment of infection. And this is a point which I would like to stress to my younger colleagues, my residents, that don't feel shy of doing debridement, adequate debridement. Get rid of all the sequestered bone, sinus tracts, loose implants, and at least you should have a bleeding fiber bone that is called paprika sign. Use a burr and make sure that ends are uniformed and matched, because at the docking side, this will have a bearing, because that compression will promote union. So one of the problems which I face, if you are not using, if you have a large gap, as you're transporting, the transporting segment may deviate actually. And to control this, what I use in a large gaps, intramedullary wire, that is Ilizarov wire only, 1.8 mm wire, which I attach to the distal ring. So like this, so that you have the good translocation of the middle fragment. So the operative steps move into like, how do you place the frame? So it has to be a proximal fixation and a distal fixation using a reference wire, so that frame is adequately placed both in coronal as well as the sagittal plane. Then you augment the frame by placing other wires. So it could be an all wire like Dr. Bari, which even I use all wire frame in tibia, or it could be a pin wire, which is called hybrid fixation, or all pin, which probably the adult surgeons may be using. And you have the 3 sets of wires, which I think we all are familiar with: the axial wires, the fibular wires, and the medial face wires. So these are workhorses. Now, what I use, these customized leg holders, which maintain alignment and make ease of wire insertion, in which I use often in tibial Ilizarov application. So application of pre-construction frame, the leg is centered. It has to be a leg-centered frame, not tibial-centered frame, and make sure you have adequate 2-finger bed space all around. So this is the slide which I hope my younger friend should remember. The first wire is always a proximal reference wire. And the common mistake what we make, I'll tell you, and I use a 5/8 ring which allows knee flexion. It has to a lateral to medial wire, just proximal and anterior to the fibular head. And I hope those who have done the deformity course, they must remember the MPTA. It is 87 degrees. So it is not exactly parallel to the tibial articular surface. It makes a 3-degree offset. So in a fluoroscopic view, it is closer to the medial articular surface. If you're trying to align the frame with the proximal reference wire, which is parallel to the articular surface of tibia, you will have a valgus frame. So that is a common mistake. So it has to be a smooth wire so that you can centralize the frame in the coronal view, in the AP view. So, and what is the technique? So common to minimize this pin wire, basically wire tension, and to minimize the movement, what you should do is in a knee extension, pass the wire from lateral to medial. So once you have done this, as it exits the medial cortex, before exiting the skin, knee is flexed to 45 degrees, that is mid-range between extension and flexion. And then you pass or tap the wire through the skin on the medial side. Now, once you have done this, what you do is cut the wire on the lateral side to create a sharp tip. And now you withdraw the wire from the medial side so that sharp lateral end passes inside the skin and soft tissues. Now, with the knee in 45 degree of flexion, the wire is hammered back from the medial side. Now, what you have seen, now you had this puncture wound now moves few millimeters away as tension is taken away from the wire side. And this technique basically helps in pin side problems, wire side problems like loosening and infection. So this is a technique which I want my younger colleagues to follow. So distal reference wire, you can use either axial wire, but preference is using a transfibular wire as a distal reference wire from posterolateral to anteromedial about 5 to 10 millimeter from the distal articular surface and parallel to the distal articular surface of the distal tibia. So like this. So now once you have done this, your frame should be well stabilized and centralized. No, the ring should be perpendicular to the tibial axis, and the threaded rod should be parallel to the tibial axis in the lateral view. So you augment the frame using the other wires like fibular wires, medial face wires, and the frame should look like this, that in the AP view, central bone should lie over the tibial crest, and in the lateral view, the rods should be parallel to the posterior tibial cortex. So a well-stabilized, well-aligned frame will ensure that there is no axial deviation of the transporting fragment. Now, what I use is rubber stoppers, especially what I've observed that it holds the dressings. And another observation which I could see that the wires, they are source of trouble. So what I have learned seeing the Heisenberg is that I break the wires because we are rarely retension the wires, and if required, we can pass another wire. So this definitely helps, makes the frame much more comfortable. Now, regarding the giggly sauce corticotomy or low energy osteotomy, which I have just discussed, it's like my favorite, which I have learned from Dr. Katani, and he has been doing it regularly, under whom I did my fellowship. So it is done either in the preferably in the proximal tibia, outside the zone of pathology, and it eliminates the possibility of incomplete osteotomy. It's a little difficult. It has a learning curve, but has distinct advantages. There's a clean-cut radiographic confirmation. No need to disassemble the apparatus, what we do in a conventional corticotomy, and the healing index remains the same. And in fact, most of my residents are now also doing this, though it does involve a risk to neurovascular structure if you're not exactly following the technique or you're not subperiosteal. So you follow the principles of distraction osteogenesis, that is rate and rhythm. And these are some of the challenges which you see, like poor regenerate or docking site issue, though books say there are 50% chances of non-union rate, soft tissue invagination, and this picture taken from this article, they propose a transverse incision to remove the interposed tissue, freshen the ends. But what I have observed that at the docking site, I continue the compression till there's a deflection of 1 to 2 millimeter of the wires, and at times this causes pain. So I rarely see the non-union at the docking site using this technique. So I'll show you the couple of cases, examples to highlight the technique which I have just shown you. So this 23-year-old male actually had a closed fracture and interlocking nail outside, which got infected. So he came to me with this. The nail was removed earlier, and this was the about 8 centimeter bone was dissected. And then we used the technique of bifocal bone dissection. And this is the, you can see the corticotomy using giggly saw and over the intramedullary wire. And with the 5/8 ring, he could have a good range of knee motion, and make sure that during the consolidation phase, the patient continues to ambulate, as Dr. Bari has stressed. The load and the movement, which Dr. Ilizarov always stressed, should be promoted. So the frame should be as stable as possible and as comfortable as possible to allow patient to bear weight. Okay. So this is after about 9-10 months, and he's fully corrected. The bone is well aligned, and he has a good range of movement. So another case, 8-year-old girl presented with this chronic osteomyelitis. Here I preferred a 2-stage. In one stage, I debrided and used the beads, locally made cement beads, and used a temporary external fixator to stabilize it. And after 3 months, this Ilizarov was done, unfortunately, by one of my assistants. However, it was led to again docking site non-union, probably due to some what I could see that frame was not stable enough. So we had to revise it, we had to redo it, and this was doing a distal corticotomy using intramedullary wire, and she could walk. And I always use a principle of ring block with 2 rings in each segment, which makes a frame very stable, and that's our union. Another case of 13-year-old boy, actually old case, May 2014. He had an open fracture. This was the fixator. Actually, even fixator was not properly applied. One could see that it's not following the principles of stability. And as expected, it led to non-union infection, and there was bone loss. So he presented like this, and he had this Ilizarov done outside in December 2014, somewhere else, which again had the problem of like non-union. So he came to me in September 2015, and just to showing his face that he was anxious, depressed. Then you have all the problems like non-union, shortening, scarring. So this again, using the principles of bone transport, this is during the destruction phase, and this is during the consolidation phase. I make sure that patient continues to walk during these frame application. And that's with the frame, he has been walking. And that's after almost like year. He has a good range of motion and almost like a normal mechanical axis. So probably the last case, this 13-year-old boy again had an open fracture, a fixator given, and presented with this non-union. And this is following the principles of biological destruction. So he had a good union with almost complete range of knee and the ankle motion, as you can see. Now, just before I finish, let me just show you some of the challenges or complications which we fail to highlight. We usually see a transient knee flexion contracture if we have a large proximal gap and we are doing proximal to distal transfer, and equinovarus foot contracture when we are doing distal to proximal transfer. As this picture will show, as you are doing distal to proximal transfer, the origin of tibialis posterior moves proximally and making the foot into pulling the foot into equinovarus. And one of the solution is to enclose the foot, especially for a large distal gap, include the foot to prevent this kind of complication. Another unforeseen complication which happened to me almost like 10 years back, this was the case of non-union, gap non-union, where I was doing this distraction. And on the day 42, I could see that ankle is getting subluxated. And that really confused me. And after discussing my seniors, I could see that this problem could be a wire in the middle fragment, fibular wire, which has engaged the fibula, the transporting fragment like this. And this is pulling the ankle into varus. So this was subsequently revised. The wire was removed, reverse distraction was done, and ultimately it united well, and which we subsequently published in the JBGS. So these are some of the complications which I hope no one will have and one can avoid with diligent care. So the last take-home message is to plan well and make a frame stable, comfortable, using the following the principles of ring block, tensioning the wire adequately, follow the principles of the biological distraction, and anticipate problems and follow the patient. In fact, one of the, I would say, disadvantage of Ilizarov surgery is, as compared to arthroplasty surgeon, is arthroplasty surgeon goes back happy after doing his hip and knee. But with Ilizarov, it's actually, once you have done with the surgery, you have to follow the patient till it is adequately united. And even after that, you have to follow on a day-to-day basis. So anticipate problems, follow the patient, and take remedial measures. So thank you very much.
Yes, sir. Thanks a lot. Any questions from the panel? Or shall we move to any questions, sir?
Shamsul, can we have the questions at the end?
Yeah, we can.
After all the cases.
Perfect, sir. Perfect, sir. Now I request Dr. Pritish for his case presentation.
Yes, sir. Thank you, sir. Is it visible, sir? Yes, now it is visible.
Please go full screen. Yeah.
Yes, yes. Thank you, sir. Thank you, Vikas, sir. Thank you, Dr. Bari, sir, and Manish, sir, for an elaborative talk. I will keep my presentation very short. I will present only a single case, and with the theme that host biology is also important, as well as local biology is also important for healing of infected non-unions. Also, we do many cases, but I'll focus on these two aspects: host biology and local biology. So I'll be presenting a case of 20-year-old male. He was a heavy smoker. He was addicted to many substances like opium, extra, and he had poor general nutrition. And he sustained a grade 1 open distal tibia fracture, and which was operated primarily by any surgeon with open reduction, plating, and bone grafting also, with a good intention. But the wound did not behave in a desirable way, and wound issues persisted. It got converted to a discharging sinus, and subsequently there was failure of the implant, and more symptoms started appearing at the local fracture site. So when the patient presented to me, and I extracted the implant, and negative pressure wound therapy was started for the wound. But since the general nutrition and host physiology, they were compromised, the patient was also cachectic. He was on and off doing these addictions also. So there was flare of pus also, despite the best of treatment and despite best of my debridement. So again, I took him for OT, and I found that there is circumferential degloving of tissues in the distal tibia. And later on, I put him, I kept the wound open and applied some corrugated rubber drains for dependent drainage, did dressings, and then shifted him to negative pressure wound therapy. Now the wound behaved slightly in a desirable way, and the wound started shrinking. So in the end, the wound shrank gradually, although there were some soft tissue issues, and sinus also, it healed gradually. After healing of sinus and after healing of wound, I took him for Ilizarov ring fixator. I operated him with local repeat debridement, acute docking at the fracture site, and primary and proximal corticotomy to equalize the limb length. and it behaved in a nice way. And after 7 months, since there was host local biology was also disturbed, there was circumferential degloving, and patient was also having some poor nutrition with substance abuse and the smoking also. So there was some delay in the union, but end of 7 months, I could achieve union. There was a cross union. It was a cross union between tibia and fibula, and limb length was equal. There was no symptoms at ankle, and patient started walking on the PTB brace. The corticotomy also through good reason rate. Also, there although there was some angulation, probably there was some instability at proximal ring, which a similar case, a elderly female with diabetes. Someone operated for a undisplaced fracture of tibia, and it did not behave in a nice way. There was wound dehiscence, the implant was exposed, and there were multiple sinuses also. So I operated him with Ilizarov ring fixator, thorough debridement, lavage of the intramedullary canal, and software guided realignment. And in the end, it healed. So I wish, using these two cases, I wish to stress that host physiology and local biology, they are also key factor in treatment. Yes, debridement, stability, ring fixation. So they are already integral part of treatment, but these things also play vital role. Patient, we must care for nutrition of the patient and local biology, and ensure that there is no addiction to the patient, smoking and any other substance abuse. Thank you.
So shall I bring Dr. Shaldar's case now?
Agree.
Good evening, everybody. Hello, I am audible. Dr. Shamsul, I am audible.
Yes, sir.
Yes, sir.
Yeah. I am presenting a case of non-union tibia. Yes, my slide. Yeah, this was the compound fracture, lower end, both bone leg. Dr. Shamsul, slide चलेंगी कहाँ से? हाँ, yeah.
You just have to say next.
Next. He is 32 years male, had roadside accident with fracture both bone. Next. The external fixator was applied, and negative suction dressing was done. Next. The skin grafting was done, wound was covered. Next. Now the real challenge is, this is external fixator, is a gap non-union, and there is a bag of bone in the lower end of the on that lower 1/4 of the tibia. And the most common complication, infection, skin loss, shortening, bag of bone, and instability is there. Next. So what is the basic requirement of fracture healing? Stability of bony fragment, number 1. Number 2, optimally preserve blood supply. Number 3, biological hormonal stimuli in order to unite. This is very important, and corticotomy does this. Number 4 is preservation of limb function. Next. So this is AP and the lateral view.
So Chandra, are you connected? Let me just call him. He's just coming back. Till Dr. Shailendra is back, can we discuss Dr. Pritish's case? Manish sir, over, sir. Do we have any questions on Dr. Pritish's case, sir?
Pritish, no question. It's very good.
Yes.
No question, very good. Nicely presented.
Thank you, sir.
Exactly.
Time constraints.
Hello.
Yeah, Dr. Shailendra is back. I'll just sharing again your case.
Hello, Dr. Shamsul.
Yes, sir.
Hiya.
Yes.
Yes, this is a non-union, infected non-union. Then what you will do next? Shamsul, next. Yes, how it is planned. This is back. Dr. Shamsul, back. This is our planning. This is a lower 1/4, the tibia is bone loss. So we plan corticotomy in the upper end and the compression or docking at the lower end. So these planned it. Next. So what are the basic principles of Ilizarov or dissection osteogenesis? Next. The law of Julius Walls, when any bone is subjected to compressive force, is start consolidating to a stronger bone. Next. Another principle is accordion maneuver. An alternate cycle of dissection compression at delayed or non-union site will trigger bone regeneration. These are 3 principles for Ilizarov. Next. We simply apply 4-ring Ilizarov. Next. As usual, we dissect the first and second ring corticotomy and the compression at the fracture site. Next. Dissection at 1 millimeter per day. Next. This is post-op X-ray. The corticotomy is done at the upper part and there is decreasing the gap in the lower part. Next. This is dissection of the corticotomy. Next. This is dissection and there is no gap between the bone ends. The bone ends is approximated, but there is no sign of union at the docking site. Next. So what to do? Third method is accordion method. We compress on the docking side, then we dissect at the compression at the lower end fracture ends. Then start the process of callus formation. Next. This is the callus is formed. The Ilizarov was removed and protected in the plaster cast. This fracture union was achieved. Next. This is complete union is achieved. Next. This, from here to the union site. This is the magic of Ilizarov. The simple principle of compression and dissection at the non-union site will trigger the union. So the beautiful results. Next. This is clinical result. Next. Clinical full function of ankle joint. Next. This is pre-op, then after the finishing of the result. Such a simply done technique of Ilizarov. Next. The Ilizarov provide relative stability with minimum damage to the soft tissue and disturbance with the blood supply of the bone. Next. It is very simple, easy and minimally invasive stabilization of the bone. Next. When all else fail, think of Ilizarov external fixator. Next. All complicated cases are very well treated by simple Ilizarov, 4-ring Ilizarov, 5-ring Ilizarov. Next. This is salute to the Ilizarov. Such a difficult deformity is corrected very well. Next. Thank you. One more case. Dr. Shamsul, next case. Yes, most commonly we will find these type of cases in our wards. The one side amputation was done and the fixator was applied on the next side. Next, pre-op X-ray, infection with deformity with alignment. Next, same debridement was done. There is no callous sign of union, anything. Next, same after removal of fixator. Then we planned for Elizarov, 5 ring applied, corticotomy done in the upper ends of tibia, and the compression after debridement, the compression at the fracture site was done. Next, same EP and lateral view. Next, there is a approximation of fracture site and opening of the corticotomy. Next, same. Next, this is corticotomy is opening up. I took a fibular graft in between the fracture fragment. I do the mistake. Never do this. Next, corticotomy is opening up. Fracture is, this is corticotomy is opening up, but there is no sign of union at the fracture site. Next, the corticotomy start uniting, but fracture is not uniting. Then we again do the dissection at the fracture site after compression. That shows the signs of union. Next, yes, this is a non-union. This is hypertrophic non-union at the site of the fracture. Next, accordion maneuver, there is start uniting after accordion maneuver, dissection and compression alternate. Next, corticotomy united, fracture also going to unite. Next, fracture uniting. Next, yes, this is fracture is uniting, corticotomy is fully consolidated. Next, this is complete union. Next, AP and lateral view well aligned. Next, this is clinical photograph. Process at one and other leg is fully weight bearing. Next, this is a good result for Elizarov. He is working very well. Next, thank you.
Thank you, Dr. Shailendra. Any questions regarding this case? No. Do you have Dr. Rafi from Kerala, from BS Group, to share one case? Dr. Rafi, are you there? No. Yes. So, any comments from the panel regarding these two cases? Manish sir, Bari sir, Omar sir?
I want to pass one comment, observation only.
Yeah.
Regarding the Dr. Shailendra's case.
Yes, sir.
Everything is okay. Only one thing is proper dressing with the rubber stopper. This is the basic principle you must put through the wires. And dressing nicely so that the wires are not visible. I have seen in your case, the wires are free and no dressing, no rubber stopper.
Yes, can I answer?
Yes.
Sir, initial for 5 or 7 days, they say dressing is done. After that, there is no need of dressing. Patient go to the washroom
No. Basic principle, Elizarov principle, you must put the rubber stopper. Rubber stopper has got the 3 functions. Your all wires are visible. It looks ugly because you're not maintaining the proper way. This is the basic principle. Your wire should not be visible. This is number 1. Number 2, whenever doing proper dressing, it looks nice. When the Russians, they see like this, what you are doing, they're telling all the time like this.
So,
you cannot pick
none
it
of
open.
the wire is infected. None of the wire is infected.
No, this is wires are open. It looks ugly. When patient walks with these wires, it is the other people, whenever it looks, it looks ugly, and this is not advisable. Even if you read the Campbell Volume 2, you'll see the use of rubber stoppers and proper dressing. It's very nicely, it looks nice with that. If it is open, it looks ugly, too much ugly. Lots of, whenever anybody sees, look at this, oh, these are all wires are visible. Otherwise, everything is okay. Only this is the basic. You must put the rubber stopper with proper dressing. Everything is okay. Your case is fantastically treated. Only this.
Yeah. Thank you, sir.
Dr. Shailendra, can I ask you a question, if you don't mind?
Sir. Yes.
I feel that it was not a hypertrophic non-union. The fracture type, it was not non-union.
Not hypertrophic. It's not lack of compression at the fracture site.
No, you told hypertrophic. See, hypertrophic,
No. It's a hypertrophic type of ends.
No, it is hypo or hyper. Because
hyper.
I heard hyper.
This end was hyper.
Hyper, it is not hyper. Why it united, I'll tell you. Because you did the accordion maneuver, compression distraction, plus you did a proximal corticotomy. So basically, it was a hypertrophic non-union, which went into, you increase the blood supply and the biology. That's why it united. See, why, if you would have just done a compression, it would have not unite at all.
Yes, sir.
But this was, if you see the X-ray, it is not hypertrophic. So I will classify.
Not the hypertrophic. So at the time of compression, when I do the corticotomy start consolidating, but the fracture site was not consolidated because there is less compression. So I did full compression, then distracted.
It was a good case, but why it went into union? Because you did a proximal corticotomy and which improved.
Corticotomy, yes.
But I think
corticotomy is a stimulus for union.
You avoid telling this as a hypertrophic non-union. Okay?
Yeah. It looks like.
No, it does not look like.
No, but not hypertrophic.
This is not hypertrophic. Correct.
See,
it's not hypertrophic. Not hypertrophic.
It is an elephant foot. It's a diameter is more at the fracture site as compared to the shaft.
Yeah.
Okay, chalo. But it's an excellent case. It went. See, ultimately the result what it counts. So it has given a good result. Okay.
Vasu sir, Satish sir, any comments? Omer sir, any comments? Dr. Varanako, any comments? Please unmute, sir. Omer sir, please unmute.
Thank you so much. Thank you so much. No any comment. Nice presentation.
Thank you, sir.
Yes, sir. So we had an excellent discussion. Jayant sir, are you there, sir?
Shamsul, Andre is sitting. Probably
Andre sir.
Comment. Andre
sir, please, sir. Your expert comment, sir. Please unmute, sir.
I think his presentation is very good and very interesting cases. And I want to thank all the lecturers. It was interesting and interesting case. I want to say two words. In the many presentation, I see the very thin leg and big rings. And the rings is maybe very big. And by it's not so good because then the length wires more, the tight these wires is the less, and the fixation fragment and fixation these wires was not so good, and this may be problem for this. And one thing also, in the Ilizarov fixator, we can not only distraction, compression, we make the special deformation for the good position for the repair of the skin and the soft tissue. For the infection and the and other defects, skin defects, it's maybe very useful. For the special deformation and the good for the tubes, after that we can the same time repair of this deformation and the traction for the tubes and the bone transfer in the same time. I think it's option may be useful for our patient. And thank you for this case. It's very interesting. Thank you.
Thank you, sir. Thank you, sir, for the valuable comments, sir. Manish, sir, we had 2 questions from YouTube in the chat box. Manish, are you there, sir?
Yeah, I'm there.
Sir, it was from Dr. Vidyasagar. The first question was, is there any risk of non-union at corticotomy site? And second, intramedullary wire is to maintain alignment, how to apply?
Intramedullary, okay. See, what is the risk of non-union at corticotomy site? Yes, there is if you do not do the corticotomy properly. Like Dr. Bari has told you that, I do not elevate the periosteum. Okay. Now, if you elevate the periosteum, you use an oversized osteotome and you have to do a low friction. But I used to do lot of giggly saw. I still do giggly saw in tibia, but my main liking is for the classical Ilizarov technique. I use the osteotome. In femur, yes, sometimes I drill holes or with a small bit. But if you do not do properly corticotomy, you can have non-union. And one caution that in infected non-union, if there is lot of pus and you are excising the bone, avoid doing corticotomy at the same time, because I had 2 cases where I had burnt my fingers. If the corticotomy gets infected, you had it. So I always, what I have made this thing that I infected non-union with pus, I excise the non-union, make the gap, put a drain, don't do corticotomy at that step. But then I go after 2 to 3 weeks and then do corticotomy and then do the transport, because I have failed miserably and really had a difficult time when the corticotomy got infected. And second question was the intramedullary. I do it, I put a closed wire in the fibula. It is, you put a wire at an angle at the tip of fibula, and I use the Ilizarov wire because it is flexible. So if you put a flexible wire, it is easily you can negotiate in the fibula.
Right, sir. And Dr. JAYANT Agrawal has asked to explain the chipping technique again. Yes, sir.
Dr. Shamsul?
Yeah, please.
Unstable corticotomy can go to non-union. If corticotomy is unstable, then it goes to non-union.
Yeah, the regenerate will be poor, and certainly,
Yes.
What I've observed, the people who smoke a lot, you should avoid doing corticotomy, because regenerate is poor and hypertrophic. So avoid doing an unstable. The frame is not stable, it will fail.
So Dr. Basan has asked to explain the chipping technique again, if possible.
Yes, I use it quite often. See, it is used in non-union. And this is a paper, if you go to the literature, you'll find many papers, but this is, by a Japanese surgeon. So what you do that, there is no requirement for any bone grafting. Just make a small incision, maybe a 0.5 mm incision over the non-union side. First you apply frame, stabilize it, and then if there is no deformity, first apply frame, stabilize it, and just take a 0.5 mm osteotome and just start, chipping that area. When the whole area, small chips, and you have to be very careful that you do not shatter the bone. And once you have done that, adequate chipping, just leave it. So don't give a big incision. Don't do it. Is everything is closed. This is the chipping technique, and it works. And I avoid sometimes, many times I have avoided bone grafting at that site. But this works very nicely in hypertrophic non-union. But you should avoid doing it in atrophic non.
Thank you, sir. There was a case from WhatsApp from one of the young surgeons, Dr. Rafi from Kerala. I'm just sharing it. So this is a case of a 60 years old male, RTA 6 months back, initially treated with X6 with multiple VAC and SSG. 6 months back, treating with bone grafting done, went for infected non-union, plate removal and antibiotic cement is one by back. Now SR and CRP, WNL. How to proceed?
Yes, I will comment on it. See, Dr. Rafi, you have to avoid putting this, antibiotic bone on a wire in the medullary canal. See what happens. I had 3-4 cases which were operated outside. If you have to put a cement in the medullary canal, it should be always over a K-nail, because when you try to remove this thing, what is going to happen? The wire will break and you will have horrendous time removing the intramedullary cement portion. So always, if you have to do intramedullary this thing, you basically put a nail, a 7 or 8 mm K nail with the sleeve of cement, and then put it. And this beads, you have to put it outside. Now, this is a very highly infected case. If you see this area, this is the bone ends are sclerotic. So the best option in this thing is that you open it up, do the debridement, see the paprika sign which Dr. Bari has told, excise till the paprika sign, create a gap, apply Ilizarov frame and transport it. This is the best option in this. Plus
Yes,
the fracture is distal. So you have to also see that I feel that patient might be having equinus, because if you see the position of X-ray, but to prevent it, you should also put a foot ring to correct the equinus at the same time, and you have to do the transport.
Antibiotic cement beads started given when 1 month back.
Dr. Rafi, are you here? Please answer.
See, this thing, because I have burned my fingers. Don't put intramedullary cement with a wire inside the marrow. You will have a tough time. Sometimes the wire breaks and cement you cannot dislodge. So always put intramedullary on a nail. Beads have to be outside.
Plating, listen. Can I pass comment?
Yes, sir.
2 wrong things done here. See, I don't know whether patient is diabetic or non-diabetic. 60 years old, lower 1/3 of the tibia, nutrient vessels already gone. See, bone quality is not good. Done plating. This is the lower third, not a good option. Again, then remove the plate and given the cement. This is second wrong thing done. Now, the Manish Dhawan told, just he removed, go for punctate bleeding, paprika sign, good the debridement. Your gap is 3 fingers, no problem. Go for lengthening, do corticotomy, and then lengthening bone transport, and it will help. Reverse vascularization, new vascularization you will get in the whole limb, and you will get a good union in the lower 1/3 of the tibia. So, and at the same time, I'm telling you, look at the ankle joint, osteoarthrosis of the ankle. And at the same time, you put a half ring in the calcaneum and go give the distraction for 10 mm. Then you can prevent the osteoarthrosis of the ankle joint. and ankle joint is going to be damaged, you see here. And same sitting, you can correct the ankle osteoarthrosis and you can achieve the union by doing the corticotomy, removing, refreshing, everything remove and put a guide wire inside to maintain the axis. Okay?
Thank you, sir. Thanks a lot, sir.
Just do the debridement, apply 4 rings and corticotomy in the upper tibia.
And ankle destruction.
And
you don't do that because your distal tibia is minimum. Your ankle joint is damaging, painful ankle. To that ASD, articulated hinge destruction by Ilizarov. Only half ring and go for destruction gradual and you will have a very good movement, circulation. And one thing again, I can tell you the upper tibia in the metaphyseal region, corticotomy and drilling by drill bits 2.5. This is the Shepsom's methods to increase circulation. And if you have distal tibia metaphyseal, you do the drilling, you can increase circulation. And I do that also.
Prasad sir, any comments, sir? No. And Professor Andres sir has emphasized a very important point about the ring size, Bari sir. Ring size is a quality of vase. That is important. It was very big ring size. Your
Yes.
comments about that, sir, Bari sir. The points that
see,
Andres sir elaborated.
G, I am telling you, most of the rings use a smaller rings for more stability. We know the theory 2 fingers. Use a smaller rings for more stability. Use larger rings whenever necessary. But most of the cases, the Andrei Kaminsky, he observed already, see, from the Kurgan center, your ring size is bigger all the time. As a result, you cannot get the stability. And tension of the wires is not proper in most of the cases he has observed. And they see all, these are the basic principles. You can put Ilizarov whatever you like, wires and these, but tension of the wires and size of the rings, these are the basic things. Stability is very important because Ilizarov ring and the wires, this is the flexibility. Ilizarov wires and K wires, there is a difference between Ilizarov wires and K wires. Ilizarov wires is more flexible. If you see Kurgan wires, their wires are more flexible. But we are telling all the time we are using Ilizarov wires because you are K wires. We are using K wires in not our legs, in patient's legs. That's why we are not thinking about that. The bone properties are 3: isoelastic, hydrostatic, and pneumatic. These are the 3 properties of the bones. Why they are using the wires flexible? These wires coincides with the properties of the bones. Whenever you are putting the Ilizarov wires with the biocompatible thin wires and you are giving load and motion, you are increasing circulation in the whole bones. That is the main principle. And unfortunately, most of the orthopedic surgeons, we are Ilizarov surgeons, we are doing this hybrid, using lots of pins. Pins gives rigidity, but Ilizarov has flexibility. This is the difference. So he has observed the Andrei Kaminsky that your ring size is bigger than normally. So theory is 2 fingers, okay. Sometimes whenever you think that you are getting this compartment syndrome, swelling, at that time you can use the larger rings, but not all the time. My short size is 16.5. If I use this 23 size short, how it will look? That's why he has observed. That's why. This is his message that I'm going, and he's smiling. See. Okay.
Thank you, sir. Thanks a lot for the very good interaction. Jen, sir, are you there, sir?
Yes.
So, sir, shall we conclude, sir? We can have a concluding remark from your side, sir.
It was a nice discussion and covered almost all the aspects of non-union with really good cases from Shailen and PRITISH. It was a learning experience for everybody, and the new I mean, the budding orthopedic surgeons would learn a lot from lecture of Manish sir. And Vikas sir also gave a real good tip of what to do and what not to do for infected non-unions. Professor Bari, as usual, is the master of the Ilizarov procedure, and his contribution was equally appreciable and worth learning. I thank everybody for their contribution and taking out time for this masterclass. Over to you, Shamsul.
Thank you, sir. So thanks everybody for attending here. Thanks for all the national and international faculty. Stay tuned for next month, first Friday, 8 to 10 p.m. for another very interactive webinar. So with this, I'll be saying good night to you all. Thank you. Thanks all for coming. Thank you, sir.
Bye-bye.
Thank you, Shamsul.
Thank you. Thank you very much. See you again.
Thank you, sir.
Bye-bye.
Okay.
Can we
Good night.
start the live?
Thank you. Thank you. До свидания. Andrei Kaminsky. Okay, Shailendra.
Goodbye, my friend. Goodbye.
Yes.
Goodbye.
See you
Goodbye.
soon. See you soon.
See you soon. See you soon. Okay.